The content of this podcast is based on medical fact and evidence-based practice from credible authoritative sources, but is not a substitute for your institution's policies, procedures, common sense, or good judgment. The views and opinions are those of Eric Bauer and Flightbridge Ed in their entirety.
Hey everyone, my name is Mike Lauria and welcome back to the Flightbridge Ed MDCast on our series on OB critical care. So this is the 5th episode in our installment of the MDCast and OB critical care. And today we are going to be talking about the dreaded amniotic fluid embolism, or AFE. My name is Mike Lauria. I'll be your host today. I am a emergency medicine physician, critical care physician, and EMS physician at the University of New Mexico, and a flight doc with our transport program. This whole series is brought to you guys because I think that maternal mortality has been on the rise and is a major, major problem in the United States of America. We are now 65th in the world in terms of our OB mortality rate, up to about 32.9 deaths per 100,000, which is quite a few compared to other developed countries, for example, in Europe, that have a rate that's close to about 1, 2, or maybe 3 deaths per 100,000. So we're not doing so great in that area. And we need to be concerned about this. In the transport world and critical care transport, we need to be concerned about this because as the landscape of healthcare changes in this country, we're seeing a substantial proportion of births taking place at hospitals that don't deliver a lot of babies. And with the closing of many OB units and lack of access to good OB care in very rural areas, sometimes a lot of these patients are going to present to small critical access facilities, and we are going to have to transport them to larger tertiary and quaternary centers. I also want to emphasize that critical care for these patients is it does not stop at delivery. Absolutely not. Getting the baby out is not always curative, and about 65 to 78% of major complications and deaths are after delivery, in the minutes, hours, and weeks after the baby is born. So, and of course, these patients are generally young and relatively healthy beforehand, so good critical care and transport can be a big win. For the series, and here to help me, I have the illustrious Dr. Elizabeth Garchar. So Liz is actually a obstetrician and maternal fetal medicine specialist that actually is very unique in the sense that she is one of our assistant medical directors here at our flight program and flies with us regularly. So she knows what we go through in the back of the aircraft and what we experience at some of these sending facilities. So welcome, Liz.
Thank you so much. It's my pleasure.
Before we get going, Liz and I have no conflicts of interest. If we talk about something, we think it's good science or a good thing to do. We're not getting paid by any companies that produce devices or do anything. And of course, remember that we're discussing the evidence in our practice, guidelines, etc., but it is never, ever, ever, ever a substitute for your local protocols, guidelines, regulations, or legislation in your state. So always follow your local guidelines, regulations, and laws. Without further ado, let's start talking about AFE. So how common is it, the epidemiology of amniotic fluid embolism? Well, it's definitely less common, but again, like many of these other conditions we're talking about, can be very, very severe. So less common in the sense that it occurs in about 1 in 13,000 to about 1 in 50,000 births in the United States, but the morbidity and mortality are super high, so between 13 and 30%. So if a patient has an AFE, up to a third chance of death in these situations. So definitely really, really morbid condition. But it's actually very hard to say exactly how frequently it occurs and what the mortality is, because the overlap with actually a lot of other critical conditions. And that, of course, changes the definition of what the criteria are. So keep that in mind. We may actually be underestimating how often this happens, and we may actually be underestimating the mortality and morbidity. So what is AFE? So how do we actually define amniotic fluid embolism or describe it clinically? Well, generally it's characterized by what is very often sudden hypoxia, hypotension, hemodynamic collapse, followed by coagulopathy in a pregnant patient. From a historical perspective, it's interesting when you go back and read some of the reports. This was originally characterized as early as the early 1900s, when it was referred to as obstetric shock, which was a very feared complication of pregnancy and cause of sudden death that was very poorly understood. And in 1941, actually a pathologist at the University of Chicago found what they thought was mucin or squamous cells in the maternal pulmonary circulation of a patient that suddenly experienced hemodynamic collapse and coagulopathy, which they believed was actually amniotic fluid. So that's how it's got its name. We'll talk about later how that's not the whole story, but that's how it got its name. And since then, hundreds of case reports are published in literature, but it's just really hard to pin things down because, again, there was uncertainty regarding what actually defined AFE. So for purposes of diagnostic criteria, there's essentially 5 things from a research standpoint, from an academic standpoint, that we say defines or describes AFE. 1, sudden onset of cardiorespiratory arrest or both hypotension, described as a systolic blood pressure less than 90, and respiratory compromise, so dyspnea, cyanosis, hypoxia, like a pulse ox less than 90%. 2, documentation of overt DIC following the appearance of these initial signs and symptoms. So often respiratory distress, hypoxia that comes on suddenly with associated profound hypotension, and then following that, DIC. And if you want to learn more about DIC, make sure you check out episode 4 where we discuss that topic in depth. Number 3, coagulopathy has to be detected prior to the loss of sufficient blood in and of itself that can cause shock and coagulopathy. So it's basically saying this is not due to a hemorrhage, it's not due to an abruption, it's not due to a source of bleeding. And the clinical onset during or within about 30 minutes of placental delivery. So there is a temporal component of this. If it happens, if you get called to transport a patient and it's 5 hours after they've been delivered, you should be thinking about other things. And of course, no fever, so no evidence of infection. So essentially, if you boil those 5 things down, it's sudden hypoxia and hypotension with DIC that is not caused by sepsis or other sources of hemorrhage and happens very shortly within or before the baby getting delivered. So what's the pathophysiology of AFE and amniotic fluid embolism, which actually very interesting. Again, like so many of these things in the world of OB critical care, the pathophysiology is incompletely understood. And initially, like we said, based upon some of those initial studies, if you will, or case reports of patients who were post-mortem, it was thought to be literally like a bubble or embolism of amniotic fluid or tissue that caused mechanical obstruction in the pulmonary circulation, causing sudden hypoxia, hypotension, etc., etc. And believe it or not, I'm a little embarrassed to admit this, but up until very recently, after medical school and after residency, just recently, did I learn that? Because I always used to say, because of the name, I used to think it was like this fluid that like leaked into mom's circulation and then obstructed flow. That is, in fact, not the case. It is not giant bubbles of amniotic fluid that get wedged in the pulmonary circulation. Interestingly enough, some women without clinical evidence of AFE have elements of amniotic fluid isolated in their blood. So some women with the clinical definition of AFE have actually not had elements detected in their blood. So it's not necessarily linked to directly the presence of or absence of amniotic fluid. So as Dr. Garchar has told me, actually it's kind of like an allergic reaction. It's somewhat idiosyncratic, and we don't exactly know why some women with some of these elements detected in their blood don't have it, and some in fact do. Actually, the amniotic fluid or fetal material may have various structures or chemical compounds or vasoactive and procoagulant substances. So, for example, prostaglandins, platelet activating factor, or the dreaded bad player in so many obstetrical conditions, tissue factor, that gets released into the maternal circulation and causes things. And there are two general phenotypes, this more cardiovascular, more pronounced cardiovascular phenotype, and a more pronounced hematologic or coagulopathic phenotype. Often, as we said, for kind of the academic definition, they have to coexist, or they are both there. But like many things, sometimes one aspect of the spectrum is slightly more pronounced. The cardiovascular phenotype, we think that especially in these cases, tissue factor can cause this profound and prolonged pulmonary vasoconstriction that results in this very, very sudden increase in RV pressures and dysfunction. Because remember, think about like the LV, it's like a Mack truck, man. That thing can push against very high pressures, especially chronically. But even acutely, the LV has enough muscle that it can actually push against a pretty substantial pressure head. The RV is not so much, right? The RV is like a little Mazda Miata. Like, it can go fast and it can do its thing, but if you hook a trailer up to it, it is not going to do very well. It is going to struggle. So sudden, profound increases in RV afterload can be very, very devastating. That can cause RV failure, and then that RV failure, when the RV can't push blood through the lungs to the left ventricle can't squeeze much out at all, and therefore that leads to sudden and pronounced decreases in cardiac output as well as hypoxia. In terms of from a hematologic perspective, it often follows that very sudden cardiovascular collapse that can catch people very much off guard. But that tissue factor, remember, it's also part of the extrinsic clotting cascade. And that extrinsic clotting cascade, which is mostly driven as a function of calcium tissue factor, factor 7, triggers clotting, the clotting cascade, and this diffuse consumptive coagulopathy and DIC. Again, I'm not going to spend too much time on that because I will refer you to episode 4 of the OB Critical Care series where we talk about it in depth. But what causes this shock and sudden death? Well, primarily, it's not necessarily from the DIC and the bleeding, but it is really this cardiovascular RV spiral of death, as it's been described. That very sudden increase in pulmonary vascular resistance causes a sudden increase in RV afterload, which results in RV failure, decreased cardiac output, and when the cardiac output goes down very suddenly, remember this RV that's struggling to push blood through this tremendous increase in resistance through the lungs, it's really working hard. Now imagine you decrease the cardiac output and that RV, it becomes ischemic. And when you add in ischemia to superimposed hypoxia and hypercarbia, which the patient gets because they're not perfusing very well, we may or may not be oxygenating them very well or ventilating for them very well, that makes the RV failure even worse through a poor RV function, inotropy, a increased RV afterload with the hypoxia and hypercarbia, and that leads to worsened RV failure, and that is sort of this downward spiral where the RV suddenly and very rapidly fails, and that is bad news. So, Liz, let's talk about things that crews can identify, signs and symptoms of AFE that crews should be on the lookout for, or if they're responding to transport a patient that is believed to have an AFE, what they should listen to in the history.
Yeah, so some of the things that, as we alluded to before, is definitely that it has to do with during labor or shortly after placenta delivery. So this is someone that's acutely delivering, or that right after that was when they had this collapse. And almost 100% of those in the national registry for this, which is small but mighty and continues to grow, experienced hypotension, as well as fetal distress if you're still pregnant at that point. So you're having things like decreased variability or marked fetal bradycardia. So the baby looks terrible and the mom becomes extremely hypotensive as well. You also get that hypoxia, pulmonary edema, or ARDS, and that's really mostly at least outlined with subjective dyspnea, if not hypoxia and all of those other things. And then 87% of them progressed rapidly to cardiac arrest. So both mom and baby suddenly progress to complete cardiac arrest, which is really terrifying for sure. 30 to 48% of them did have clinical evidence of a seizure or seizure-like activity as well at that time. So that's something that wouldn't rule it out. So if you're listening to a report and they said, but she had a seizure, so I don't think it's an AFE, that's not something that should be tipping your hand one way or the other, although it's something else to consider in that setting and think about. But it is something that has been identified a fair amount of the time as well. With that doesn't mean that it's easy to diagnose. It's something that's really hard to pin down. It's something, obviously, we don't even know exactly what causes it, right? So it's mostly a delivery arrest is kind of like the main things. And it can mimic a lot of other things. So don't forget to think about the seizure-like activity, seizures, PE, postpartum hemorrhage, abruption, eclampsia, septic shock, other things. So don't automatically assume either, and do look for underlying causes, as you will if you listen to the DIC lecture C or DIC podcast is very important. So don't forget to think about other things, but it is something that should be on your mind if you have an arrest around the time of delivery of a baby or of the placenta itself. So,
absolutely.
Go ahead. Sorry.
So I think one of the things I just wanted to touch on and throw in here is, as more and more flight crews are becoming facile with ultrasound, I think it's reasonable under these circumstances to at least discuss briefly what echocardiographic evidence you may in fact see that may lead you to this diagnosis. So oddly enough, in the literature, there are a couple of reported cases of patients that actually had a TEE in situ, or were in the OR and had the ability to drop a TEE around the time that they decompensated, or already had a PA catheter in place, which is pretty wild, and I would say is exceptionally rare to have this before an arrest. But when they were able to actually see some of these things, what they found was, surprise, surprise, pressures in the PA catheter skyrocketed, super high PA pressures. Again, something we're probably not ever going to see in a pregnant patient, but that went along with echocardiographic evidence. In this case was TE, but you can absolutely see it on transthoracic echocardiography, evidence of elevated pulmonary pressures and RV dysfunction. So decreased LV filling, so a small underfilled left ventricle, an enlarged and poorly functioning RV with sort of grossly looking like the RV is bowing into the LV, like you would see potentially with a pulmonary embolism, for example, and basically encroaching on the LV chamber, and then evidence of RV pressure, load, and failure. So some things you may see as well, not just the septum bowing in, but a very large proportion of the apex of the heart, where it's normally made up of the left ventricle, now will be largely the right ventricle pushing over. And if you have the ability to do some echocardiographic parameters, you can actually look at how the heart is squeezing. So you can look at things like TAPSE or S prime. So that is the tricuspid annular plane systolic excursion, how the tricuspid valve is actually moving when the RV squeezes. Or the S prime, which is essentially a measurement of how quickly the tissue is moving in systole. So if you can actually look up those numbers, and you can see, and actually with some very simple echocardiographic tools, you can generate a pretty good picture, both qualitatively and quantitatively, to see if that RV is functioning well. So now, general approach to cardiovascular collapse in this setting and or management shortly after ROSC. So Liz, I'll throw this one out to you as you've seen more of these than I, but can you just run us through how you approach these cases?
Well, this one isn't very different from other cases where you're having that sort of pathology. So there's not a specific thing that you need to go to for specifically AFE because there's really little evidence of there's one thing that makes this cardiovascular compromise better. So what you really want to focus on is how do you deal with a acute decompensation of the right ventricle. And so that's something that thanks Mike for teaching me about different mental models to think of how to make the right ventricle work as well as it can. And the mental model that I've learned from Mike is from Sarah Krager, who's an EM intensivist, that really has a 5-step program to try to help that right ventricle in order to do the best it can in this situation where we need to support it for this situation. So the first thing is something that I'm super guilty of as an obstetrician, which is be careful with your fluids. Don't give too much volume. And that's something that I reach for 100% of the time. Most of my patients are in their 20s. You could give them 10 liters and you probably would just have them pee it out. But this isn't that patient. So don't blow out your right ventricle by giving them tons and tons of volume. You're just going to distend the right ventricle worse, and that can make the ischemia worse as well. So then you're going to go back to your cycle of death with that and getting back to not having enough of your output from the right ventricle, and then you're going to end up with a decrease in your left ventricle in preload. So hold off on those fluids that I love very much. The second thing is to increase your systemic blood pressure, and therefore, of course, you're increasing your coronary perfusion pressure by doing that as well. So going back to norepi or vasopressin for that situation is really important. The third thing is to decrease your right ventricle's work, right? So decrease that afterload. And this is something that is not exactly super well studied in the literature in this setting particularly, but makes intrinsic sense in the setting of a right ventricular failure that's in this acute situation. So adding things like inhaled nitric oxide, some EPO, or even nitroglycerin can help with that. Those are your quickest options and things that you may have on hand, maybe. You might also, if you look in the literature, find things that talk about a more long-acting thing like milnirone, sildenafil, or IV prostacyclin, but that's not something you're going to see in critical care transport. The fourth thing of our 5 is to increase your right ventricular inotropy, so giving epi or dobutamine to help that right ventricle keep working as hard as it can. And then the fifth thing, although I would say most of these patients will be intubated, don't intubate if you don't have them already and you can avoid it. So that will drop your blood pressure because you're given those drugs to do an RSI. And also you're going to end up with lots of positive pressure, and that's going to be pushing back on that right ventricle that we're working really hard to preserve in this situation. So again, number 1, watch your fluids. Number 2, increase your systemic blood pressure. 3, decrease your RV afterload. Increase your right ventricular inotropy. And don't intubate if you aren't already given an intubated patient.
Absolutely. And I think that this is always very, very challenging wrapping our head around this because that's a very challenging pathophysiology to manage in and of itself. But then superimposed on that, we have managing the coagulopathy, which we just said, right? Like watch your fluids, be careful with your fluids. And unlike other patients, postpartum hemorrhage patients or some of the other flavors of DIC that we see, giving them a robust blood product resuscitation is not a problem. But in this setting, it might be. So from a managing coagulopathy in this setting, Liz, how do you do that?
Yeah, so to manage your coagulopathy side of things, we have a whole episode of DIC in pregnancy, so do go back to that, just a little plug. But one of the most important things is don't be a victim of looking at the computer or waiting for labs. You're going to have trouble getting those back. So go to things that if your outside facility has something like a viscoelastic testing, like a ROTEM or a TEG, that's going to be the way that you want to go because those you would see most successful in treating DIC, which in pregnancy specifically, because it's a snapshot in time where you're actually at with your resuscitation at that moment. And then another thing is to remember to transfuse liberally in the DIC setting. Again, we're getting back to our balance of fluids, but activate that massive transfusion and start with plasma and cryo if AFE is suspected, because that's, although not exactly in the 1-to-1-to-1 ratio that we hammer home all the time, is good to get back up your, especially fibrinogen in the setting of cryoprecipitate, in order to try to counteract the DIC you have. But do be careful with your hemodynamic parameters. So don't get too intense with this, I guess. It's a balance, right, as is with many really complex conditions such as AFE. And so remember that we have to watch our volume.
And in talking to a couple of other people about this topic, I think one of the, again, we're talking about managing two pathologies simultaneously that are both super morbid and really challenging. And I've had a couple questions in the past, like, well, how do you give all these blood products then? And if you're trying to treat this patient, well, to be completely frank, this is not something I manage on a daily basis. Very rarely have I had the opportunity to manage some of these patients, as have, I would say, most intensivists, because it is pretty rare. And the best advice that I've gotten is, once you get the hemodynamics under control, going ahead and starting with and we do have clinical evidence of DIC, starting with the blood products, but being as careful as possible, sometimes even watching echocardiographically, if you have access to ultrasound, watching how that RV is responding and what their cardiac output is doing as you're giving them blood products, and try and be as conservative as possible in terms of the volume. Because one thing that the quickest way to make the situation worse is superloading that poor, struggling right ventricle. That would be game over, unfortunately. Now, in terms of terminal and maximal support for these patients, it is mentioned in the literature, and of course at larger centers that are capable and really love doing extracorporeal support like we do here at our center. I hate to say this, but it is easier said than done in these situations, especially in the retrieval setting. Although it is possible, it may not be logistically feasible under some circumstances, as patients can deteriorate so quickly that it will be difficult to rally resources. And as we know, many flight programs around the country don't have access to cannulation teams or whole teams that can go out and actually make this happen at sending facilities. There are some case reports of saving AFE with VA ECMO, but remember, these are case reports, and there's really no robust evidence that exists. So as much as I love ECMO, I can't get out here and tell you that this is a terminal therapy, or this is a therapy that I would recommend rallying for these patients on this time course. And recall that for transport providers, again, this is generally not something that we'll be doing at outside facilities. Of course, you may have a patient that is actually cannulated at an outside hospital, and you may be transporting on ECMO. And in that case, we will be doing a whole episode on ECMO transport of the critically ill OB patient. So that's to come. But let's go on and say that you may have a patient that actually has an AFE or gets really sick as you're getting ready to transport her and goes into cardiac arrest. What we want to do here is do a quick spaced repetition of managing cardiac arrest for maternal cardiac arrest patients that we talked about in a previous episode. Remember, be prepared for rapid deterioration and cardiac arrest from these patients, because as we mentioned, almost 90%, 87% will progress to cardiac arrest. And of those, 40% progress to cardiac arrest very rapidly, i.e. the definition in the literature of very rapidly was within 5 minutes, so fast. It's a little spaced repetition, like I said, on maternal cardiac arrest. Remember the child mnemonic, CHILD. Number one, call for help. If the nurse and the sending provider have left the room for some reason and things get worse and the patient goes into arrest, call them back, call everybody, and get as many hands as you can, especially if you're at a smaller outside hospital. H is for high quality CPR. Remember that this is really our only one of the few stopgaps that might actually be super helpful. So remember your really good hand placement, defibrillate the patient as you normally would if you see a rhythm that can be defibrillated, and make sure you have as best recoil of the chest as possible and minimize your hands-off time. So good, high quality CPR. I, get IV access, and often more IV access that you're going to need. You're going to need plenty of medications and, in some cases, some resuscitation fluid, usually blood or blood products. So get robust IV access and make sure that we are displacing the uterus off the IVC. So as much as we, in these cases that RV is struggling, we want to make sure it has reasonable preload. It's hard, I think, in these circumstances to really recommend not doing left uterine displacement with the concern that the RV is already overloaded. Because remember, there are other things that can cause maternal cardiac arrest, and we would hate to miss one of those. And then D, delivery decision ASAP. So talking to whatever provider is sending them and making the call if this patient is in cardiac arrest, especially from an AFE, are we going to progress to emergency resuscitative hysterotomy? And for that piece of spaced repetition, I'll turn it over to Liz, who has definitely done more of these than I have, and talk about emergency resuscitative hysterotomy. Liz, what are we going to do and how are we going to do it?
It really, first and foremost, improves maternal survival and possibly limits neurologic damage to the fetus. So it's something that we have to think about. I'm not saying that when I finish talking about this, which I put it a little bit more surgical this time, but that you should be doing this when you see a cardiac arrest. But this is something that is in the scope for definitely the EM providers. And if you happen to have an OB, around, that would also be good. Or a general surgeon, bringing someone who operates and have them help you out in these situations for sure. So it's really important to get it started, get thinking about that delivery decision, because we want to start our C-section or resuscitative hysterotomy within 4 minutes and have the baby out within 5 if possible. So you want that because you're going to remove the uterine contents, relinquish your aortic cable compression, which will help you with your attempt to get Roskin mom. So it's helpful for both, especially if the fetus is viable, although I would argue that if you can palpate the fundus, if you can feel the uterus and it's at the belly button or higher, your umbilicus, then you should be doing it because it can actually help with your aortic cable compression and save mom. So how do you do this procedure? So use the incision you're most comfortable with. So if you're going to be calling your general surgeon or someone like that, you're probably going to have a midline vertical incision. And that's what you will see in the literature because that's what we're aiming at, is people who aren't doing a lot of C-sections, but how do you get down the layers, essentially? I personally am a lot faster at a fan and steel incision, which is 3 centimeters superior to the pubic symphysis and about 11 centimeters in length horizontally on the abdomen. So people will call that like a bikini cut, but whatever can get you down faster is the right decision for sure. So if you're looking at a midline vertical incision, which is what you'll find when we discuss resuscitative hysterotomies, you'd start at the same point, about 3 centimeters superior to the pubic symphysis, which is about 2 finger breadths, and then go up just inferior to the umbilicus. That should give you plenty of room, especially in a distended abdomen of a pregnant mom. You're going to go through the skin and subcutaneous tissues, which are the Camper's and Scarpa's fascia, and then you're going to see a white fascial thick layer, and that all to that layer of the fascia should be done with a single pass of your scalpel. You want to go slow enough so you know where you are, but also as fast as you can. Trying to get down through in a minute can be really challenging, so you want to keep that balance of both. So now you're at the fascia, so you should just open it a little bit, about 3 centimeters or so, at the level you expect to have only uterus present. So kind of on the lower side, but not too low. And in the middle, it would probably be about the middle of that incision that you're making if you're making a midline vertical. You can clear the layers above by pulling sort of bluntly to the level of the fascia. You know you're not going to be hurting intestines or anything because you're still above that. And then open that layer that is the fascia. And we do that as an OB pull is what you'll see us pull on both sides to rip open that fascia in order to go with the planes, essentially, of what it is. But getting through all of that at that point. When you're doing a midline vertical, it can sometimes be hard because you don't want to injure bowel or other things. But if you're starting at that point, then you're going to be in a safe place. So now you should see a very maybe thin, filmy layer over the uterus itself, and that's the peritoneum. So just going through that bluntly because you can see where your uterus is, especially at a Fannin steel incision, I always just go bluntly towards the umbilicus and then open that as well. And now you should be at the uterus itself. If you're trying to just get through it, wherever you see the uterus and no intestines is the right spot, what I'm going to be looking for is the lower uterine segment. So that's the bottom or the non-contractile part of the uterus. And that's the best place to cut through because it decreases their risk of dehiscence, but are really having a opening of the uterus in future pregnancies. But honestly, if we're not surviving this one, we're not going to be having future pregnancies. So not the most important thing here. The place to cut, if you're going at the lower uterine segment, is above the fold or right at the little fold of the peritoneum, which is the vesicouterine fold, aptly named, because it's the place where the bladder connects to the uterus or has space between them. So if you cut at that line or above it, you're not going through the bladder, especially if this is her first incision or her first C-section. So it's a good, safe place to go through. And at that point, you cut through the layers of the uterus horizontally, being careful. Ideally, you're going to get to the point where you just see the bag pop through, and you'll see a bulge of amniotic fluid in it, or just a huge burst of fluid. That works too. Now you're through all the layers, you're at the right place. So the main reason not to cut like super deep on the uterus and really be careful is you don't want to cut the baby. I've done that. You feel awful. Usually babies are fine anyway. And again, this is an emergency, so not the worst thing in the world either. And then you want to try to lift that presenting part, whatever you see, preferably the head, hopefully the head, up to the level of your incision and have either yourself or your assistant, which you hopefully have with you calling for help of everyone in the department, push down on the fundus to get baby out. What if you see feet? So just to get extra terrifying, I wanted to throw in what do you do for a breech delivery of these babies when you're doing a C-section? So if you feel feet, find them both, pull them up to the level of the incision, and proceed with a breech delivery. So you want to, if you have a towel or something like that, to remind yourself to put your hands on the baby's hips. You want to be on the bony prominences of their hips because you want to not go superior to that because you can cause an adrenal hemorrhage by pulling on their kidney area. So you want to stick to that bone, and you're going to help push superiorly or like pull the baby out with your hands. If you have, a cyst that's getting that head pushed down, that's great. But you want to gently pull until you get to the point that you're at the shoulders. And then once you get to the shoulders, you're going to stick one hand I'd like to drape the baby over my arm. And then I have my hand underneath the baby at that point. Tilt one side of the baby up, pull that arm out in the physiologic direction, which is usually sweeping it directly in front of the baby's face. Turn the other way and do the other side. And then the most important thing is to get the head out gently. Oftentimes by this point, the head kind of just comes as well, but the actual maneuver is to place 2 fingers of that hand that's draped underneath at the point just below the eyeballs or really on the maxillary prominences in order to tuck the head to decrease that diameter to get it out. You don't want to put it in the baby's mouth. You can dislocate their mandible, and you don't want to obviously poke a baby in the eyeballs. And so at that point, then you can just sweep the baby up and get them out.
Wow. That was thank you so much for taking us through that procedure. What I want to emphasize to people right now is that was an awesome, amazing review for those of us who are providers and can execute this procedure. But of course, we know that and we understand that a lot of our providers are not physicians or APPs that are able to do this procedure. That is okay. Again, we are recommending this and we're talking about it for a couple of reasons. One, even if you're not a provider that can do it, you should be thinking about it and understanding the time sensitivity. You should be pulling people in and getting them on board and encouraging people to at least think about it very, very, very early on in the arrest. Remember, getting going by 4 minutes, baby out by 5. That's your goal. Second, a lot of places that you may go and may even have to do this procedure, there may not be a lot of hands. So just understanding what Liz was talking about and the mental model of how this procedure should progress is important, so you can actually be helpful to people that are actually credentialed to do this procedure. That can be very helpful and well. And third, just knowing what to expect, I think is very important as well. So having that expectation in there that this is something that can help mom. Now, this next part is something that a lot of people are credentialed to do and are, God willing, the mom actually survives this and you have to manage her after this, is something you may have to do as a paramedic, nurse, or a provider. So Liz, would you mind going through now? The procedure is done, baby is out, actually baby's alive and doing okay at this point, but mom has an open uterus after this procedure. Can you go through how we manage those patients in transport?
Definitely. So the first thing, if we're still there with an open uterus at this point, is making sure to get all the products of conception out. So you can do just like you would from a vaginal delivery, removal of the placenta by pulling on the cord, or just having the provider scoop all of that out, because we want to make sure you're not having retained products after especially a C-section, because you have that open uterus that you can do. At that point, if you're still doing a resuscitative hysterotomy, you won't have any bleeding, but once you get that ROSC, you're going to have a lot of bleeding. And so there's not evidence that using like a laparotomy sponge or anything to clean out the inside and really get everything clean is going to help you. But the more important thing is closing that uterus. When a mom is especially term pregnant, she has almost a liter of blood going through that uterus every minute. Well, at least a little over half, 750 to 900, depending on mama. So it is something that's going to bleed a lot. So to do that, the main thing is a running locked suture from apex to apex and making sure to get the corners, because that's where those darn little bleeders generally like to sit. So closing it end to end, and that's not necessarily, again, something that you're going to be doing, but something that should be done. Or, I mean, you can always pack. Packing works. We want to try to achieve hemostasis however you can. And then after that, if you happen to have another suture laying around, closing the fascia would be great. But really the main thing is to make sure that uterus is closed and hemostatic, because that's where you're going to have your problems. How do you get the uterus to be hemostatic? The most important thing is doing fundal massage after this, even after a C-section, very important. You want to make sure that you're firming up your uterine muscles. So that can be, once you achieve ROSC, thinking about giving Pitocin at that point to try to not too rapidly, because that'll also cause hemodynamic collapse. But using your Pitocin if you need to, maybe some Methergin, especially if she's hypotensive, in order to get a firm uterus that should feel almost like a softball. And that should be at the level of the umbilicus or below, in order, if they were term at the time, in order to make sure that you have good contraction of that.
Awesome. Thank you so much for going through that as well, because that, I think, like I said, is something that we very well, if we run across this situation, may have to manage in transport. So one more time, I will go ahead and say, under these circumstances, if you have an AFE and if it progresses to this point, that this procedure saves lives. And at least a number of reviews that this procedure actually demonstrates very good survival. So in fact, in one systematic review, in cases where they had to perform this procedure, the good neurological outcomes, so in other words, a cerebral performance score of 1 or 2 being like essentially you're either completely neurologically normal, doing your job, going to college, functioning as a nurse or functioning as a banker or businesswoman, or 2, maybe minor assistance with some of your activities of daily life, was 78%, and in the actual moms, and 52% in babies. So when this procedure is done quickly, it can actually be life-saving. So we just talked about a lot. That was a relatively long episode, but I think good spaced repetition of some of the cardiac arrest stuff. We'll go over really quickly summary and Pearl. So an amniotic fluid embolism, although somewhat misleading in name, is actually a life-threatening emergency around the time of delivery that is likely some degree of immunogenic response to fetal tissue or fetal tissue chemical components, if you will, that cause major cardiovascular issues, usually profound pulmonary hypertension, IV failure and shock, coagulopathy. It happens around the time of delivery, like within 30 minutes or so, and is not associated with infection or other evidence of bleeding. It can come on incredibly fast, very, very, very sudden, and it may be reasonable under these circumstances, when there is no other clear evidence of something else going on, like this just comes completely out of the blue, think about AFE, and from a cardiovascular perspective, treat it like acute decompensated RV failure. Like Liz had said, be cautious with the fluids, get the MAP and the blood pressure up with vasopressors, decrease the RV afterload. A lot of us are flying with inhaled agents these days, whether it's either nitric, EPO, or others. Use those if possible. Increase RV inotropy, so using inotropes like epi or dobutamine, and if possible, although as Liz mentioned, I would imagine, especially if you're flying out to retrieve one of these patients, a lot of the time they will be intubated. If for some reason they're not, avoid it if possible, or be very cautious if necessary. I'll caveat a lot of these recommendations with, again, this has really not been studied. Very hard to actually study this under these circumstances, but these are general recommendations that are evidence-based, or at least evidence-informed, that under the circumstances we think may be helpful. Recognizing coagulopathy and resuscitate the patient with blood products, again, cautiously in the setting of these hemodynamic changes. Be prepared for rapid deterioration and possible progression to cardiac arrest. If they do arrest, remember those fundamentals of maternal cardiac arrest, including following the child mnemonic, and be prepared to perform or suggest and maybe even assist with an emergency resuscitative hysterotomy. All right, everyone, that is the end. That's all we got for this episode on amniotic fluid embolism. Make sure to tune in to the next episode of the MDCast on critical care OB transport. Thanks again. Take care and fly safe.
This has been a production of the FlightBridge Ed podcast, leading the way in pre-hospital critical care and emergency medicine education.